This is the final part of the nutrition lecture, and we're going to start with disorders of the gallbladder. Cholelithiasis is inflammation of the gallbladder. It's usually due to formation of gallstones. You'll have cholesterol that could be causing it, and that's cholesterol and bile combination. Or it could be pigmented, means that it's unconjugated bilirubin and calcium. Risk factors: FFF, female, fat, and 40. Or the American Indians, particularly the Pima Indians, are at great risk for gallstone formation. Oftentimes we'll find that somebody who develops pigmented gallstones will also have heart disease. So it's something you need to pay attention to, the type of gallstones that they have. Cholecystitis is inflammation of the gallbladder. Cholelithiasis is gallstone formation. So first one is formation of gallstones that can cause a blockage. The second is inflammation of the gallbladder itself. And that inflammation of the gallbladder or the common bile duct can cause ischemia, necrosis, perforation of that gallbladder. Symptoms are fever, rebound tenderness, and a high white count, leukocytosis. Oops, sorry. Push the wrong button. This is showing where the gallbladder is located underneath the liver. Has to be available so that the liver can put bile into it for storage, because that's what the gallbladder does, is it stores bile. And then through the common bile duct, releases bile into the intestine. As you can see, this is also showing stone formation and where the stones can be and how they can cause problems there. This is another one showing different places where stones can be and cause problems. Female, overweight, over 40. And here are the symptoms that go along with this. This is from the memory book. Disorders of the pancreas. You can have pancreatitis, which is inflammation of that pancreas. It's thought to occur because of injury to the pancreas or obstruction of the acini, which are the cells in the pancreas. Enzymes will then leak into the pancreatic tissue. Enzymes that are normally released into the bloodstream to digest food now start to auto-digest the pancreas. This can be triggered by gallstone obstruction of the common bile duct. It can be triggered by other things like alcoholism. Symptoms: you'll have epigastric or mid-abdominal pain, and that pain is due to the edema formation, chemical irritation, and inflammation of the peritoneum, and or obstruction of the biliary tract. They'll have fever and an elevated white count because of the inflammatory response that is initiated. They'll have nausea and vomiting due to the hypermotility, and they'll have abdominal distension because of accumulation of fluids in the abdomen. They'll be hypotensive because of vasodilatation of the blood vessels due to the release of the enzymes and the kinins that are released. They'll have tachypnea due to pulmonary complications because of those circulating enzymes. They'll have decreased output because intravascularly they will be dehydrated because fluid will be third spacing. They will be hypoxic because the ascites, you won't be able to expand the lungs as far, and so that's going to cause problems. They'll have tetany due to the decreased response to parathyroid hormone or calcium deposits in the area of the fat necrosis. They'll be hyperglycemic because glucagon is being released from the alpha cells, but the beta cells are not releasing insulin, both from the pancreas. And you'll have lipase, an elevated lipase and amylase, because those are the enzymes that are secreted to help digest protein and fats from the pancreas. And lipase is much more specific than the amylase. Amylase tends to go up rather rapidly, though. And this is showing the a flow chart for acute pancreatitis, how it will alter glucose metabolism. It affects your kidney, your cardiac contractility, your bilirubin, you name it, it causes problems. Chronic pancreatitis is usually due to chronic alcohol abuse, and it will cause pain that's worse after meals. Patient will develop steatorrhea, which remember is fat in the stool because it's not being digested appropriately. And they'll have malabsorption due to a deficiency of the pancreatic enzymes that are necessary for nutrition. It can cause type 1 diabetes mellitus, and this occurs because of loss of islet cell functions in the pancreas that produce insulin. And it still is producing glucagon, which raises your blood sugar. And they can develop pancreatic cysts that will contain necrotic debris, blood, or pancreatic juice in walled-off areas, and that makes it painful and lasts a long time. Okay, cancers of the digestive system. Esophageal cancer is usually squamous cell. It most often occurs at the gastroesophageal junction. This is due to altered esophagus structure and function. So it changes, it's due to changes in food and drink that remain in the esophagus a long time. Esophageal reflux causes metaplasia and ulceration. The chronic exposure to irritants such as tobacco and alcohol increase the metaplasia that occurs. Deficiency in your trace elements such as vitamin A and zinc, so the cells cannot re-heal themselves, and you'll have malnutrition and obesity. Symptoms are chest pain or heartburn, and heartburn is called pyrosis. It means it's burning. It is initiated by eating spicy food or lying down. Dysphagia is more pressure-like. It radiates posteriorly and it progresses rapidly. Odynophagia is pain when you swallow. Risk factors for esophageal cancer: male, 60s, African Americans. Stomach. Risk factors: males, atrophic gastritis, family history of an adenocarcinoma of the stomach, pernicious anemia, group A blood type also is a risk factor for stomach cancer. It begins in the glands of the stomach, so it produces insufficient acid secretion, thereby allows bacteria to grow, damages the DNA of the mucosal cells, and you get duodenal reflux of bile salts that damage the mucosa. Symptoms are usually only present after metastasis because, remember, your stomach can distend very easily. Think about Christmas and Thanksgiving and those meals and how easily it is to overeat and distend, and all you have to do is loosen your pants or wear stretch pants. Usually the first symptom that they're going to say is that they have a loss of appetite or some weakness, maybe some indigestion. But by that time, it has metastasized. By the time there's weight loss, it has metastasized. Change in bowel habits, it's metastasized. Vomiting, abdominal pain, and anemia also occur. There is some other causative factors, might be infection with H. pylori, highly salted nitrates in your diet, somebody who likes to eat lots of sardines or pickled herrings, low fruit and vegetables in the diet, somebody who smokes and drinks alcohol. There's a table on page 926 that talks about the risks, the cell type, and the common manifestations for the different GI cancers. Colorectal cancer is still the third most common cause of cancer death in the United States. Risk factors are over the age of 50. It's familial, high-fat, low-fiber diet, increased alcohol intake, cigarette smoker, sedentary lifestyle, and maybe somebody who's had colitis, ulcerative colitis for 10 years. That also will increase their risk. It's due to a deletion of certain genes that promote the formation of an adenoma. Dietary factors can also promote mutations, formation of polyps. It's usually a slow-growing adenocarcinoma. Prognosis depends upon the stage and the location that they get it. So it's really important to know your symptoms that go with this. It could, if it's on the right, which is the ascending colon, you'll have pain, a palpable mass in that right lower quadrant, anemia, fatigue, and your stools will be dark red or mahogany colored. But it rarely obstructs if it's on the right side. The left side is descending colon, your descending colon, and you'll have abdominal distension, vomiting, cramps, constipation. The stools will be very narrow and pencil-shaped. You'll have bright red blood on the surface of the stool. And if it goes all the way around the left, so it's circumferential, it will cause obstruction, and oftentimes then they'll have liver metastasis. Now, rectal, you'll have metastasis to the vagina or the prostate. There's a figure on page 929 that talks about colorectal cancer. And it looks practically identical to this slide. Again, this is showing different places for colorectal cancer. You've got your adenocarcinoma of the colon up in here. You've got, this is the circumferential cancer. It goes all the way across the transverse colon and will metastasize to the liver oftentimes. There's the jejunum, and down here is the rectum, rectus sigmoid colon. Liver cancer is usually the result of metastasis. It's very rarely primary in nature. Tends to occur in males over the age of 60, chronic liver disease. There's a box on page 930 that lists the risk factors. Pathophysiology is that it's closely associated with cirrhosis and metastasizes easily to the heart because it's right under the diaphragm, and right on top of the diaphragm is the heart and the lungs. And since all the blood goes through the liver, it'll get to the brain and the kidney and the spleen. Symptoms are vague: nausea, vomiting, abdominal fullness, pressure, a dull ache in the right upper quadrant, jaundice, anorexia. None of those are specific. You can't point to one symptom that says this always means liver cancer. It could cause hemorrhage, and it can worsen the ascites. If the patient is symptomatic, your prognosis is 3 to 4 months. And this is showing some common sites of liver cancer. Pancreatic cancer is the fourth most common cause of cancer deaths in this country. Again, because it is metastatic by the time it is found. It's more so in blacks, more so in males. Risk factors are smoking, diabetes, chronic pancreatitis, obesity. But you don't have to be obese. Unfortunately, mortality is about 99%. It causes a ductal adenocarcinoma that rapidly metastasizes to the common bile duct, the portal vein, the liver, the lymph, or the peritoneum. But as I said, it's not picked up until they metastasize because the pancreas has a large reservoir of insulin, glucagon, and the enzymes necessary. So you don't realize the pancreas isn't producing what it's supposed to because it can release what it's stored for quite a while. And you can't palpate the pancreas because it's behind the stomach, so you can't tell that there's a problem there. Symptoms: vague back pain, jaundice, and weight loss. Most patients will die of hepatic failure or malnutrition. At this moment in time, the mortality is 99%. Some people will live a while with pancreatic cancer. If you know who Patrick Swayze was from Dirty Dancing, and he did a TV show on one of the cable channels just before he died. He survived with pancreatitis for almost a year. That's almost unheard of. Michael Landon, if you remember him from the beginning, would have been Bonanza, but then Highway to Heaven, and you also had Little House on the Prairie and lots of other movies. He also developed pancreatic cancer. The usual prognosis is 6 months once it's diagnosed. Alteration in digestive function in children. We've talked about some of this, but some stuff just affects kids. For example, your cleft lip and your cleft palate. Cleft lip can be either unilateral on one side, on both sides. It can be partial or complete. It can be an incomplete fusion of your nasomedial or intermaxillary processes, and it occurs in the 2nd month of embryonic life. And most often, you may not even know you're pregnant at that time. It will affect the lip, the external nose, the nasal cartilage and septum, and possibly your tooth formation and or the presence of teeth. The cleft palate may occur alone or with the cleft lip. It affects the uvula, the soft palate, and can progress forward to the hard palate and the maxillary ridge. Here we have some pictures. This is showing, up here, an incomplete unilateral cleft lip. This one is a unilateral cleft of the lip, the alveolus, and the palate. Down here you have a bilateral cleft of the lip, alveolus, and the palate. And over here you have an isolated median cleft of the palate. With all of these, you're going to have a lot of trouble feeding that infant. And you'll find a picture for this on page 939. And there's a group of physicians who travel to third world nations mainly. I think it's called Smile Train, where all they do is they go there and they correct these problems, because children in those countries who have these sort of problems are oftentimes abandoned at the side of the road and left to fend for themselves. Esophageal malformations: you could have atresia, which is where the esophagus ends in a blind pouch. And so then there'll be a fistula that can connect hopefully to the stomach, but it could also connect to the trachea. This usually occurs in the 4th to 6th week in the neonate in utero. Symptoms are excessive amniotic fluid, abdominal distends with air if there's a fistula present, and they'll have intermittent cyanosis. It's often associated with other defects. And this is showing of the different types of esophageal atresia that could occur. This is the esophagus. That's right there next to the trachea. A blind pouch, no connection. This is showing the esophagus connected by a fistula to the trachea. Still a blind pouch. This is showing from the trachea down to the terminal end of the esophagus. This has got the esophagus going into the trachea and then into the stomach, to the rest of the esophagus. This one just shows a fistula connection, and this one shows a blockage right here with no fistula formation. So there's a picture in your textbook on page 940. Pyloric stenosis is oftentimes called infantile pyloric stenosis. This is due to hypertrophy of the pyloric sphincter muscle. It has an unknown cause. The incidence is greater in males, whites, and a full-term pregnancy. Symptoms are noticed in infants between 1 week and 4 months of age. They'll have vomiting without reason. Oftentimes it is projectile. They'll be constipated, have malnutrition, and weight loss. And this is showing pyloric stenosis, as you can see right here. Pyloric stenosis. This also, oops, sorry, I wanted to say something. Yeah, this occurs in infants most often. Always. Okay. Congenital aganglionic megacolon is also called Hirschsprung's disease. Must be a Dr. Hirschsprung somewhere. This is a functional obstruction of the colon due to decreased motility. You'll have abnormal innervation of the colon by the parasympathetic nervous system that results in obstruction due to a decrease in fecal movement. These children will go weeks without a bowel movement. So they'll be very constipated and will have watery stools. They may also develop enterocolitis because of a fecal impaction, and they can become septic. There is a picture of this on page 942, and here's an x-ray that shows the megacolon. Look how much bigger this colon is than it really should be. It's lying there over the spinal column. Intussusception is the telescoping or invagination of one part of the intestine into another. This usually occurs before age 2, and there are pictures on page 901 and 943 that show this. It will obstruct the venous return, causing stasis, engorgement, edema, and possibly even gangrene of the bowel. Symptoms are abdominal pain, irritability. The baby will draw up, or the child or the person will draw up their knees. They'll have emesis, and their stools will be a current jelly characteristic. And that means they're dark and look like jello, and that's because of blood and mucus content in them. And this is showing it, I believe this is a picture of a dog bowel, but this is part of the bowel. This is another part that has stuffed itself back in there. And so it's like telescoping on itself, and so nothing goes through it. Celiac sprue and gluten-sensitive enteropathy is hypersensitivity to gluten, and that decreases the intestinal villus epithelium, causing malabsorption of the nutrients in the presence of gluten. It is associated with other immune disorders. Symptoms: they'll have watery diarrhea, weakness, seizures, tetany, hyperparathyroidism, signs and symptoms thereof, steatorrhea, anemia, malabsorption of vitamin B12, so they're at risk for pernicious anemia, growth failure, anorexia, constipation, and vomiting. This tends to occur more in whites, and keep in mind that gluten is found in your wheat, your rye, and your barley. So there are a lot of foods that they cannot eat. Now, cystic fibrosis is also discussed in the pediatric chapter. Remember, we discussed that with the respiratory system. So, but children who have cystic fibrosis don't develop the enzymes that they need to digest food, their pancreatic enzymes appropriately. So that is a concern, and it goes along with nutrition. Failure to thrive is a decrease in physical development. You'll have decreased weight to height ratio, decreased head circumference, weight to height to head circumference. You'll have, the organic form is due to GERD, gastroesophageal reflux disease, pyloric stenosis, gastroenteritis, or cystic fibrosis. And all of those are treatable. The non-organic form is due to psychosocial causes, and there's a list on page 947. Symptoms are decreased responsiveness, social isolation, spasticity or rigidity when they're touched. They don't smile. They have no eye contact. It's one of the saddest things you want to see when a baby just kind of lays there and has no interaction with anybody else. These children do not do well long term. And on that depressing note, that finishes the nutrition content.